Okay.
I think that my dream has come true now because our hospital not only is able to attract patients from all over India, but we also attract patients from neighboring countries as well as from the Middle East. Even though we specialize in all aspects of transplantation, we really wanted to provide high quality primary and secondary care for the local population. We have built a hospital with state-of-the-art facilities. Our interest in transplantation includes liver transplantation, kidney transplantation, small bowel transplantation, pancreas as well as bone marrow transplantation. Our focus is also in the care of the critically ill, especially patients with multi-organ failure. To make this effective, 150 of our beds out of the 450 are intensive care beds. And these are manned 24 hours by consultants and not junior doctors.
Medical Advisory Board ensures that through compassion, innovation, technology, research and evidence-based medicine practice, Dr. Rela Institute and Medical Center provides highest possible quality of care to the patients.
Good morning and welcome to this webinar on elevating stroke care and exploring cutting-edge approaches in the treatment of stroke. This webinar is part of the Hindu's Wellness series brought to you in association with Rela Hospital. Let me begin by introducing our esteemed panelists. Dr. Shankar Balakrishnan is an interventional neurologist from Chennai. He is a fellow in endovascular neurointervention, a movement disorder specialist, and a neurorehabilitation specialist. He is a member of a number of national and international professional bodies, including the American Academy of Neurology, the International Movement Disorder Society, the Indian Academy of Neurology, and the Indian Association of Epilepsy. Our next panelist, Dr. M. Anbuselvam, is a senior consultant neurosurgeon with nearly 30 years of experience. He completed his MBBS from Keelpok Medical College in Chennai and then did his MCH from the Institute of Neurology from Madras Medical College. He has authored and co-authored a number of research publications and made several presentations at national and international conferences. Our third panelist, Dr. K. Subramanian, is a senior consultant neurologist. He completed his MBBS from Stanley Medical College and then did his MD internal medicine also at Stanley, followed by a DM neurology from Madras Medical College. Dr. Subramanian also has research publications to his credit, and his expertise is in neurocritical care, infections of the central nervous system, and stroke care. Our last panelist is Dr. J. Jayaprakash Khanna. He is a consultant neurosurgeon with 10 years of experience in neurosurgery and 4 years of experience in general surgery, vascular surgery, and endoscopic surgery. He completed his neurosurgical training from the Safdarjung Hospital and BMMC, New Delhi. His expertise and interest lies in the management of neurotrauma, polytrauma, head injuries, and cerebrovascular disorders. He is a life member of the Tamil Nadu and Pondicherry Association of Neurological Surgeons, of the Neurological Society of India, and of the Neurotrauma Society of India. Over to Dr. Shankar now for his presentation.
Thank you for a wonderful introduction. So World Stroke Day Awareness. So every year, 29th of October is observed to spread awareness about the stroke, to identify and treat early. The most important thing that we insist or we promote about stroke is how to identify a stroke and what to do next. These are the two simple steps that every public should know. So learning the signs of stroke, the facial drooping, arm weakness, slurring of speech, and they need to act in time. So sometimes they're neglecting this arm weakness, and sometimes they may even like slurring of speech is considered because of old age. These are the signs of stroke. Once they identify there is a sign of stroke, they need to reach a comprehensive stroke care center. And what is comprehensive stroke care center is? It should have a complete angio suite to treat the stroke to the maximum. So most of the places that conventional methods is followed. But here in Rela, we are acting on a unit called Rapid Stroke Intervention Unit. Every point in time. From the point of arrival, the count starts. The door to the needle or door to the knee canalization of the vessel is most important for a stroke patient. If the blood vessel got occluded, there is no blood supply, and per minute, around 19 million neurons are dying every second. So we need to open the blocked vessel as early as possible. For this, we have only 3 steps. Just we assess clinically how the patient is doing. We know whether it's a stroke, which side is affected. A quick, rapid clinical assessment. And within this time, this a clinical diagnosis of stroke is made. Our ER team is equipped 24/7 and an exclusive stroke squad team is there to assess the stroke in a rapid way. Once the clinical diagnosis is made, immediately remove the patient to a rapid sequence MRI imaging. The most important step in stroke is to identify whether it is a bleeding or a block. If there is a block, we start on an intravenous thrombolysis we call it as a clot buster. So this medicine is used to lyse the clot, and sometimes the clot may be very rigid and it will not get lysed with the medicine. So immediately we shift them to the cath lab. A cath lab is something, is a state of art in Rela Hospital, where the entire team is backing up with highly equipped equipments and facility to open up a blocked vessel. This is a rapid procedure with zero delay, and we have an exclusive neurosuit to carry out the stroke mechanical thrombectomy. So when we talk about thrombolysis, only a 6 millimeter clot can dissolve with the medicine. But most of the time, the bigger clots will not get dissolved without medicine alone. So we take the patients, we make a small puncture with a small needle, and then we pass a catheter to aspirate the rigid clot out of the system. And once the clot is aspirated, the blood vessels open up and the blood flow is restored to the brain. So this is the most important thing the family or the caretaker should be aware of: how to identify the stroke and how to open up the vessel. So a center without a facility of opening the vessel will not be able to, like, only thrombolysis is not sufficient. And every, like, the community is very aware about the heart attack, but they're not knowing many truths about the stroke. Like, the stroke is incidence and the prevalence is gradually overtaking the heart attacks, and almost every year, like every day, there are around 5,000 people are suffering with stroke, and very few people reaches the right center at the right time. So most important is we need to like understand the severity of the stroke and what it will lead to. So it can lead to a complete disabled state. A breadwinner can become a disabled and a dependent for the family. It can change the life upside down. So the myth is only old people can get strokes is a myth. So stroke can occur to anybody, even younger people. Now after the COVID, there is a surge of increase in number of young people coming to stroke. The first steps is to identify a clot and where it is located. It can occur to old, occur to young. Only the etiology means the cause of strokes is different in old and young. So the blood vessel gets clotted and there is no blood supply to the brain corresponding regions. The right brain controls the left hand and the left lower limb, as well as the opposite side controls the opposite. No, so now how to prevent stroke? 80% of the stroke are preventable with a healthy lifestyle. Our food matters, regular control of blood pressure matters, keep your sugars under control all the time. Low cholesterol is always good, and smoking and drinking is not always like go with the strokes. And sometimes the heart is also important. Some arrhythmia can throw a clot which can lead to stroke. So again, in instead, if somebody with a facial drooping and an arm weakness or slurring of speech, act in time, take to the hospital, I call for the ambulance, and they need to reach in time so that we can save them. And these are the common signs of stroke. Apart from the common signs, sorry, there are loss of balance, blurring of vision, and sometimes numbness. These could be a sign of a stroke. So when we identify the stroke at the right time, we are chasing the time. Actually, every second matters in stroke. As time progresses, the size of the infarct increases and line-neck neurons dies per minute. To prevent this, what we need to do is reach the hospital in time, take the help from the specialist to treat them in a comprehensive stroke care center. So the comprehensive stroke center is not like it occurs in every places. We work on hub and spoke model. Every small hospitals, when they come across, they can identify the stroke easily and refer to a nearby comprehensive stroke center where an MRI or a CT facility, as well as the most important is an exclusive cath lab should be there to open up heart vessels and heart block. Brain imaging is important to identify two things. One is whether it's a bleed or is a chance of like a clot, and what is the intensity or the burden of the clot. So once we identify early, the disability is less. And every hospital has the facility to lyse the clot within 4.5 hours. Somebody reaching beyond 4.5 hours, or if the IVTPA, the clot buster, doesn't work, that's not the end of the story. Now we have the facility to open up a blocked vessel with the help of cath lab and mechanical thrombectomy. So even patients who are little away from the window, thrombolysis cannot be done, but mechanical thrombectomy is an option for them. which is available now 24 by 7. So when we talk about clot blood vessels, the simple thing we need to understand is it is a clot sitting on your blood vessels, blocking the blood supply to the brain, and we need to open it up. That's simple. So nowadays the technology is so advanced. Without opening the brain, a small puncture, we can reach the clot easily and aspirate the clot under a little pressure so that the hard clot can be aspirated. Sometimes a rigid clot can be taken out with the help of a stent like material also. So this facility is a boon for like stroke. And once the patient is out of all these procedures, rehabilitation is something important for the completion of care. So those patients who comes out of window period or a late stroke, they will require an intense rehabilitation to restore the life. In rehabilitation, a speech therapy, a communication, a swallow, and a physical movements, and all can be achieved with the help of a comprehensive stroke care center, which is there available in Rela. So identify stroke faster and act fast. So this is the message that we are spreading because our loved ones they need our care, and sometimes the rehabilitation is also a part of an acute stroke care, which enables us to communicate, interact, and be independent and be ambulant, which is very important in elderly. So, identify strokes at the earliest possible. To restore the life back to normal, we need to know and learn these signs again and again. What is stroke? Spot a stroke and reach the right center so that you can save your loved ones at time. Thank you for the opportunity.
Thank you very much, Dr. Shankar, for that very informative presentation. Over to Dr. Anbu Selvam now for his presentation.
Thank you. Good morning to all. I'll be talking to you all about the role of neurosurgery in the management of stroke. As you know, the stroke has got two types. One is the ischemic stroke, where you can see as the dark shadows in the CT scan of the brain. The other one is the hemorrhagic stroke, where you see the blood as bright white here. Now, acute stroke care management is mainly medical and interventional. The role of surgery is there in acute ischemic stroke, in acute hemorrhagic stroke, as well as in the prevention of stroke as a secondary prevention. Now, this is the CT scan of the brain showing the large black area of the brain which is infarcted. The skull cannot expand. When there's a large part of the brain is infarcted, it swells up and it pushes the brain to the other side. When it does so, it presses on the deeper main important structure of the brain called the brainstem, which controls your heart, which controls your breathing, which maintains your consciousness, which controls your movements of the legs and arms. That area gets affected, and once the pressure keeps going up, the patient can become comatose and he can die as well. To prevent that, we make a large incision in the scalp like that, and we open the skull like putting so many holes and take out the bone, and we cut the covering of the brain in this fashion to allow the brain to expand to the outside rather than pressing on the deeper structures, and we cover the scalp. And later, once the pressure settles down and the patient is rehabilitated, we cover the skull defect with a titanium mesh, as you see here, which is a custom-made 3D mesh, which is put within a month or within the first 3 months. And this is another area of the brain. This is called the cerebellum or the small brain, which is just behind the ear. When this part is infarcted, it presses the brainstem directly and can cause the person to die in a very fast manner. So a quick surgery by removing the bone here, as you see here, the bone is removed so that the brainstem is relieved of the compression and the patient can get better soon. And this is an excellent surgery with excellent results for the patient. And sometimes diseases like moya disease, where the patient gets recurrent strokes, there is a blood flow to the brain is gradually cut off. We do a surgery called cerebral revascularization procedure by doing superficial temporal artery to middle cerebral artery bypass, wherein the blood vessel from outside the brain is taken into the skull and it is anastomosed with the blood vessel in the brain to augment the blood flow to the brain. So that's about the ischemic stroke, where we have a role wherein the patient who has got a large hemispheric infarct or a cerebellar infarct. By doing so, it decreases the intracranial pressure and improves the cerebral perfusion, and patient have improved functional outcome as well. It reduces the mortality. When it comes to an hemorrhagic stroke, as you see here as a large bleed in the brain, that constitutes about 20 to 30% of the stroke, and it's a deadly disease with a 30-day mortality of 45%. High blood pressure, amyloid angiopathy, patients who are anticoagulants, antiplatelets, coagulopathy, those who have liver disease with coagulation disorders, those who consume drugs like cocaine, amphetamine, all these people are vulnerable for these kind of bleeds. And patient can have bleed into an infarcted area as well. Apart from this, an aneurysm or LV malformation or conditions called the vascular disorders can cause subarachnoid hemorrhage. And these are all accentuated by consuming more alcohol and smoking. Here is a patient with a large bleed, and an angio is done to rule out vascular malformation, and a craniotomy and evacuation is done. This is a post-op delayed scan showing good recovery. And as I said earlier, in the cerebellum, in the small brain, when you get a bleed, again it presses the brainstem. So where we have to act very quickly, remove the bone, take out the clot, patient can recover very well. And these black cavities are called ventricles, wherein normally you have cerebrospinal fluid, and patient can have bleed into this called intraventricular hemorrhage, where we put a small hole and put a catheter inside and drain the blood gradually, and patient can get better. And minimally invasive procedure like using a brain path or an endoscope through a small hole to remove this clot are also very helpful. See here, I'll show you a small video clip where a small hole is made and this is called the brain path, which is passed in. Once the hematoma cavity is entered, the hematoma clot is slowly sucked out, and once completely it's cleared, you can see the normal brain pulsating there. Then we achieve hemostasis, and this is a post-op CT showing complete evacuation of the clot. And sometimes you may not need to evacuate a small bleed like this thalamic bleed or a small bleed in the subcortical area. But this is a scan that is showing a bleed in the brainstem, which I was telling you earlier about the important structure. We see a lot of young people with a high blood pressure coming this kind of bleed where there's no role for surgery, and eventually this has got a very high mortality, almost 100% mortality. So the importance of blood pressure control is very, very, very important here. There's a subset of patients who have another kind of stroke called subarachnoid hemorrhage due to vascular malformations like AV malformation or aneurysms. This produces bleed in the covering layers of the brain. This is also a devastating disease where you see the subarachnoid hemorrhage, the angiogram showing the swelling in the blood vessel wall. And here a 3D CT showing nicely that aneurysm, which is clipped. So I'll show you a small surgical video clip. There's an aneurysm here, and you do a surgery, you open the skull, and under microscope, you have to operate very delicately because you are in close contact with the major neural vascular structures like optic nerve here, third nerve here, and the internal carotid artery nearby. So you gently dissect and reach the aneurysm. You see this aneurysm here. Once you see the aneurysm, you put a clip across to avoid the blood going back into the aneurysm so that you can prevent future rupture of the aneurysm. And you can see that the normal blood vessels are not disturbed by clipping, by injecting the dye and seal. Another, this is an AV malformation where you see the bag of worm appearance. This is also can rupture and cause bleed. Again, there are many modes of treatment are available. One is surgery, where you can see under the microscope and resect, and this is a post-op angio showing resection. And as I was telling about earlier about secondary prevention of stroke, here you see a carotid artery with a narrowing of the vessel. You see here, this is a normal external carotid artery, but the internal carotid artery is almost blocked by the atherosclerotic plaque, where we do this is a neck part. We open the neck, expose the carotid artery, open it, and remove this atherosclerotic plaque to establish the blood flow. So a special mention needs to say about intracerebral hemorrhage of pregnancy and a newborn. As we all know that pregnant women are prone for eclampsia and they can have intracerebral hemorrhage present as stroke and as well as subarachnoid hemorrhage. And in the postpartum period up to about 8 weeks or immediately prior to the labor, they can have cortical venous thrombosis and have stroke-like picture. So management depends very specifically according to the gestational age of the fetus and the condition of the mother. In newborn, they can have periventricular and intraventricular hemorrhage. This also to be dealt according to the status of the ventricular size and the bleed size. So prevention is better than cure. We cannot modify our age, sex, race, but we can modify the other factors. Our lifestyle modifications can be done. Controlling of the blood pressure, controlling of sugar, cholesterol, proper diet, proper exercise, avoiding alcohol, quitting smoking, and pregnant women to have proper antenatal care. All these can lead to stroke-free life. So together we are greater than stroke. Thank you.
Thank you very much, Dr. Anbu Selvam, for that very useful presentation. Let's move on to the questions now, just to get a few basic questions out of the way for the audience. Dr. Subramanian, could you speak to us a little bit about the risk factors for a stroke? Dr. Subramanian, you need to unmute.
Is it audible now? Is it audible?
Yes.
The
Yes.
risk factors are generally divided into two basically. One is modifiable and another is unmodifiable. The modifiable risk factors are diabetes, hypertension, cholesterol, smoking, alcohol. All these can be controlled. And there are certain factors like age, race, and then sometimes the genders, especially the old age, males are more common than females. So these are all unmodifiable risk factors which cannot be controlled. Sometimes there are some genetic disorders which also produces stroke. So those things are not under our control, but still we can work on. So these are all common risk factors for stroke.
Thank you, Dr. Subramanian. There's one audience question, Dr. Jayaprakash Khanna, if you could take that. The audience member is asking if a stroke can occur twice, like you have been treated once for it, but can it reoccur?
Yes. There are conditions called wherein there is a brief stop in blood supply to the brain. These are called as a TIA or a minor stroke, wherein in a transient ischemic attack or a brief stop of blood supply to the brain, it recovers within 24 hours. So the patient can present with symptoms like a brief speech disturbance or weakness of either an upper limb or a lower limb, but it recovers. Wherein a minor stroke, the deficits are permanent. These two are warning signs that the patient should not ignore. They have to immediately come to a hospital because we have to modify their risk factors and there are surgeries that can prevent a major stroke in future. If we can modify the risk factors like hypertension, diabetes, alter lifestyle like smoking or alcohol consumption. We have to follow it strictly. And if there is a surgical indication wherein we can restore the blood supply to the brain by surgery, it has to be done. If there is a small segment of the blood vessel that is blocked in the neck that supplies the brain, we can do a procedure called as carotid endarterectomy, wherein we can re-establish the blood supply to the brain. There are also procedures of cerebral revascularization, wherein if these large blood vessels are not amenable to treatment like endovascular removal of the clot or by carotid thrombectomy, we can establish an alternate pathway from a different vessel to re-establish the blood supply to the brain and restore the circulation and cerebral reperfusion. So yes, there are infarcts that can recur and there are also treatments that can prevent them from recurring. Thank you.
Thank you, Doctor. Moving on to another audience question. Dr. Shankar, if you could take this. One of the audience members wants to know if there are any medications that actually can prevent it before it occurs, before a stroke occurs.
Okay, so if before that's called the stroke risk assessment is done. So whenever we do the stroke assessment risk, we look for evidence for are they prone for stroke. There are medications like blood thinners, like aspirin and clopidogrel. These medications will help in preventing stroke, especially those are at high risk. If their scan shows a small block or if the sugars are uncontrolled, and like strong families of strokes. So all put together, we do a risk assessment, and if the risk assessment is in favor, then we need to protect them with these medications. So it is always the risk versus the benefit. When the benefit is good, it's always better to protect them with medications.
Thank you, Doctor. Dr. Anbuselvam, if you could take this next one. You talked to us a little bit during your presentation about surgical options. Could you talk to us in a little bit more detail about what happens in the case of a large brain blood clot?
There is a large blood clot. You mean, and there are two things: clot in the blood vessel or bleeding into the brain. I think you are meaning about bleeding in the brain.
I mean it in the brain, yes.
Yeah. Not all the bleeds in the brain need surgical intervention. Smaller ones, we may not need surgical intervention. And larger ones, if the patient is, all the patients are put on medical management only initially, controlling of the blood pressure and medications to reduce the cerebral swelling. Like we call it as anti-edema measure. There are certain drugs to reduce the pressure. But despite that, and if the patient's neurological status deteriorates, then we go in for a surgery. The surgery can be an open surgery where we open the skull and open the covering of the brain, and using microscope through a small incision, we get into inside the clot and suck out the clot and come out. Sometimes we may not be able to take the clot if the clot is deep-seated, and if there is a lot of pressure effect, we just do a hemicranectomy, that is open the skull and open the covering of the layer alone and leave the clot without any disturbance. Then the patient will also improve well. But sometimes if the blood clot, if it is moderate size, and we can do minimally invasive procedure like using an endoscope, or as I said, a brain path wherein you pass a smaller size tubes inside without opening the skull, by doing a small hole and putting these instruments inside, entering the hematoma cavity and sucking it out. They also have good results. So these are the ways by which we remove the hematomas inside the brain.
Thank you, Doctor. Dr. Subramaniam, another audience question. Is a person who has had a previous incidence of heart disease more vulnerable to a stroke?
There are certain heart diseases which directly or indirectly produces stroke. Sometimes, if the heart doesn't pump properly, you have a stagnant blood in the left side of the heart, which can go up. And sometimes, when your rhythm is not good, which we commonly call as atrial fibrillation, if that is also there, the chances for stroke is very high. And sometimes infections in the heart, or it is infective endocarditis, where there is vegetations, like there is infection in the valve leaflets, which can also go up. That can also produce stroke. So, in old age, both coexist, like cerebrovascular disease as well as cardiovascular disease. The atherosclerotic coronary artery disease is also very common. So there are chances that you may get from heart also. There is high incidence, especially in the old age people.
Dr. Jayaprakash, another question from the audience is about blood thinners. Since a lot of people are these days on blood thinners, what happens when people who are on these medications get a stroke?
The patients can be on blood thinners for a variety of reasons. One can be even a prophylactically or prevention of a stroke, they can be started on blood thinners, or there can be some other problem that necessitates them to take these medications. Uh, these medications we can differentiate mainly into antiplatelets and anticoagulants. That means these antiplatelets act against the platelets and decrease the quantity, whereas the anticoagulants mainly decrease the functionality. So, first and foremost step when there is a major emergency, infarct, a bleed inside the brain, we have to stop these medications immediately. So the second step is the reversal of this problem in clotting mechanism, because if any procedure we are going to take up for this patient who are on blood thinners, that adds to the risk of a new bleed or a new clot forming there, be it as an intervention or be it as a surgical. So we have to optimize their coagulation or the clotting mechanism before taking them for any intervention. So we have various mechanism of assessing this bleeding tendency by doing a thromboelastogram or a test called as a ROTAM. So once we get to it, we start them on by on drugs that can reverse this coagulation problems. For patients, especially who are on antiplatelet drugs, we transfuse them with platelets. And for anticoagulation drugs, we are having FFPs, we are having reversal agents. So depending upon which factor that is causing these dysfunction of coagulation, we have to correct them. Preferably, we have to optimize them and then take in for any procedure to avoid the risk factor for an additional bleed. Thank you.
Thank you. Dr. Shankar, could you explain to us a little bit about the golden hour, the period during which it is really vital for the patient to get to the hospital?
So as soon as the stroke onset starts, there is no blood supply. So there is no blood supply, the cells will stop functioning, but they will live. They will be alive, but they will not but they cannot function. So they will develop four symptoms like the facial drooping, arm weakness, speech disturbance, and sometimes blurring of vision and balance disturbance. So the from the time of onset to the time that the brain cells completely die off, this is called the golden time. So initial, it depends. It according to the guidelines, they say 4.5 hours is the best time called the golden time. So within that period, the patient has to reach the hospital where the clot buster can be started to lyse the clot. But as years evolve and our technology is also evolving, we are able to identify live cells beyond this 4.5 hours also. So we have this advanced method of doing a CT perfusion to see how much there is a live cell, how much the cells are dead. If there is an evidence for the live cells beyond 4.5 or so, we can open up the vessel to save those cells. So ideally speaking, the golden time is described as 4.5 hours, but still we can intervene even up to 6 hours. Sometimes we do late thrombectomy up to 12 hours also. So it's all depend now from the concept of time to concept of live tissue is coming up. Thank you.
Dr. Subramanian, could you address another audience question about whether there is a genetic component in getting in the person getting a stroke?
Yes, there are a lot of genetic disorders which can produce stroke. These strokes generally affect younger age group. So there are genetic tests available to find out who are all predisposed to that in that family. So usually they don't classically present as acute stroke. Sometimes it is over a period of time. They will have cognitive dysfunction, they have walking difficulty, and then they have bowel bladder problems. So they can present in a different way. So only imaging will guide us how extensive the disease is. So then we have to look into the other family members also. There are specific patterns in the MRI or CT which will suggest that there is a diffuse vascular disease. So in that case, we have to screen the other people also with MRI or CT, then the genetic test. And if that is there, the treatment options are very less. But anyway, we have to continue with the blood thinners and then we have to control the cholesterol levels also. If there is a large vessel occlusion, then we have to think of doing surgery or we have to do intervention procedure. Thank you.
Thank you, Doctor. Dr. Anbuselvam, another audience question. Why is surgery contraindicated in large bleeds?
If the bleed is really large and if the patient's neurological status is very poor, the chances of reviving him and getting back to normalcy will be very less. Again, it depends on the age and the side of the brain which is affected. For example, if the dominant hemisphere, that is the left side, which is affected, and if the patient's age is very old, then even we operate on a large bleed, then patient life may be saved, but he may be end up with a residual functional disability. Patient may be paralyzed on the right side, and if the dominant hemisphere is involved, he may not be able to speak or he may not be able to understand. And he may be on feet put on through tubes inside. Again, it's up to the family's wish. If the family says that we have to do everything for the patient, then the family accepts the consequences and the risk and how to take care of them, then we can do. But certain areas where the bleed is located, for example, as I said, in the brainstem, then the patient may be already very moribund and the neurological status will be very poor. Even if you operate and do something, also chances of reviving him and getting back normal will be very, very less. So there are certain places where the surgery is absolutely contraindicated. For certain places, we explain to the family, and if the family accepts, then we can go ahead. Again, depends on the centers wherein they do these kind of procedures. Thank you.
Thank you, Doctor. Dr. Jayaprakash Khanna, could you talk to us a little bit about what happens after a decompression surgery?
See, basically, whatever the problem inside the brain in stroke, either if it is due to a block in the blood vessel or a bleed inside the brain, it's going to increase the pressure inside the brain because brain is protected by a closed box, bony box called skull. So any additional insult to the brain is going to increase the volume and thereby increase the pressure inside the brain. So this increased pressure is going to get transmitted on brainstem, which is a very vital structure inside our skull. This brainstem controls a person's consciousness, breathing, and cardiac activity. So any pressure that prolongs can lead to death of a person. So what we do is we remove a large segment of the skull so that the pressure that was internally pressing on the brain is relieved and it is transmitted externally. This procedure is called as a decompression craniectomy, which means a large part of the skull on the affected side is removed. So post-operatively, there is going to be a defect and just below the skin and the layers of the scalp, the brain is going to be there. So the patient's relatives have to be aware of this fact. This may not be seen visibly because immediately after the surgery, because of the swelling of the brain, both operated and the non-operated sites may seem similar on vision. But with prolonged treatment in the ICU, as the swelling of the brain decreases, this side of the brain, due to atmospheric pressure, is going to get compressed and there can be something like a cavity. So in the post-operative period, once this edema or the swelling of the brain subsides, then we will plan for a procedure called cranioplasty, wherein we will be replacing the bone from our bone bank that we have taken from the person during surgery, labeled and preserved under appropriate conditions. That's a smaller surgery wherein we will reconstruct the skull and restore the shape and function of the skull so that the patient can go back to his routine lifestyle. Thank you.
Thank you, Doctor. Dr. Shankar, there's another audience question. Are there any screening tools to diagnose the increased risk of stroke other than a blood test? Is there some research about diagnosing with calcium levels?
Okay, so yes, imaging is the best modality to identify like who are at risk for strokes. So if apart from a blood test, carotid and vertebral Doppler is a best screening tool. It's just like an ultrasound, a small probe they will put over the neck to see how the blood vessel is and what's the velocity, and is there any, if even if there is a block, it can identify easily. So this is one of the like promising tool to identify risk factors like cholesterol blocks in the neck vessels, which makes them prone for a stroke. Looking at the calcium level, it may not directly correlate with the stroke risk factors, but carotid Doppler and transcranial Doppler, these are ideal tool to identify if somebody is more prone for stroke apart from the blood tests.
Thank you. Dr. Subramanian, another audience question about experiencing double vision after a stroke.
So we discussed earlier, there are various sites in which the blood flow block or the bleeding occurs in the brain. So sometimes it occurs in the brainstem, especially the upper brainstem, where the nerve which supplies the muscles which move the eyes. Okay. If there is any problem there, if the cranial nerve nuclei is involved, then you get a double vision. So the eyes will not be, especially if it is affected on one side, there will be double vision. So if there is an infarct or an hemorrhage in the upper brainstem, you get double vision. So this can occur in stroke. But as an isolated double vision, quite rare. Thank you.
Thank you. Dr. Andusevam, could you explain to us what a carotid endarterectomy is?
Beg your pardon, I didn't get your question properly.
Sorry, could you explain to us what a carotid endarterectomy is?
Oh, sorry. Yeah, okay. I think Dr. Jayaprakash Kanda also explained, as you know, that the blood flow to the brain is through 4 major vessels. 2 are in the front, called the carotid arteries, and 2 are in the back, called vertebral arteries. The carotid artery comes as a common carotid and divides into 2, internal carotid and external carotid artery. The internal carotid artery is the one which goes to the skull, and these 2 vessels and the 2 vessels from the back, they all go inside and they have a connecting vessels within them, and there is a flow from one side to the other. The nature somehow protects us by providing this kind of flow, so that even if one side flow is reduced, the flow from the other side or flow from the back compensates and keeps our continuous blood flow to the brain. As you know, that blood flow should be continuous. The brain should not be devoid of oxygen or glucose at any given time. Now, as we know that the front 2 vessels or the carotid vessels, the fat deposition can occur into that due to high cholesterol level, diabetes, and things because of the long-standing problem. The fat deposition occurs in the carotid artery, and it slowly builds up. It slowly builds up, and patient can be asymptomatic. Patient may not have any symptoms because of that. But patient can also be symptomatic. That is, if the right side carotid vessel is getting blocked beyond certain limits, say more than 60% or 70%, then he can experience some numbness or weakness on the left side. That's called transient ischemic attacks, or he can get mild stroke also. When such things occur, we can diagnose this either by doing the Doppler study, as Dr. Shankar discussed just now, or by doing a proper angiogram. Once you diagnose that there is a block there obstructing the carotid artery beyond a certain limit, permissible limit, and if the patient is asymptomatic or if the patient is symptomatic, then we do a procedure called carotid endarterectomy. That is, you open the neck in the front here, and under general anesthesia, sometimes they can do under local anesthesia as well. you open and expose a carotid artery, and the carotid artery is exposed. Then you open the carotid artery after doing some more procedures there. You can dissect out the complete block outside, and immediately the flow will be re-established. Nowadays, instead of carotid endarterectomy, the interventional radiologists, they do what is called as a carotid stenting as well. So there are studies have done for both carotid endarterectomy and carotid stenting and carotid stenting. So there is no clear-cut guidelines till now. But there are certain absolute contraindications for carotid endarterectomies are there, wherein you can only do carotid stenting. For example, patient who has got an irradiated neck or a recurrent laryngeal nerve palsy or a contralateral carotid artery is already stenosed. So there are certain indications wherein you will not be able to do carotid endarterectomy. You have to go only for carotid stenting if the patient is unfit for surgery or the patient is old. So there are certain relative absolute indications and contraindications for this. So basically, carotid endarterectomy is opening the carotid artery in the neck and removing the obstructing fatty block and suturing it back and establishing the flow to the brain in a normal fashion. Thank you.
Thank you, Doctor. Dr. Jayaprakash, could you speak to us about how quickly you have to cover the bone defect in the skull?
See, there are two factors. One is the patient's recovery phase and the pathology. So based upon this, the optimal time that we do a cranioplasty, wherein we replace the bone and restore the skull defect, is somewhere between 1 month to 3 months is the optimum time. Doing a cranioplasty early has many advantages because it restores the blood supply to the brain. It restores the functional aspect and protection by the skull. It increases the recovery of the patient. It avoids certain complications like a Trefine syndrome. And this is the final step wherein the patient can go back to his normal lifestyle. So the optimum period is 1 month to 3 months that we normally do. But the final factor will be the patient's recovery and the resolution of the pathology. Thank you.
Dr. Subramaniam, could you speak to us a little bit about the importance of rehabilitation post-stroke?
So once the patient comes out of the acute stage, as soon as possible, we have to start the rehabilitation process. It all depends on how sick the patient is, how much is the involvement. Suppose some patients may be totally pledging. They will not be able to move their limbs at all. Some they will be moving well, relatively well, and they may be mobile also. They can walk with support also. So it starts there. So it is a long process actually. So those patients who have severe weakness, it is going to be a long process. Those patients who are better, then if you can do home-based physiotherapy. Those patients whose weakness are severe, they have to undergo neuro-rehabilitation in a good neuro-rehabilitation center. There they have trained physiotherapists, especially neuro-trained physiotherapists. They will guide the patients and they will tell exercises, and they have instrumentations for that also, for the hand movements as well as for the weight training, all that thing, and then electrical stimulation for the muscles involved. So it is a long process if the weakness is severe. Suppose if the weakness is not that severe, the rehabilitation process is not, you can do it at home itself. So home physiotherapy. And there is a special even to speech. Speech, those who have speech difficulty, you have to assess the speech problems, how severe it is, and what type of speech problem is there. And we have good speech therapists who can assess them, and then who can give therapy for them if they have speech disturbance also. The speech disturbance varies. You can mild slurring of speech to severe form of we call it as aphasia. They may not be able to speak at all. Sometimes they may not be able to understand what we are speaking in a large stroke. So it is going to be a difficult process, and then slowly we have to rehabilitate them. Neuro rehabilitation is the combination of multiple speech therapists as well as the routine physiotherapists as well as the occupational therapists. Occupational therapists will especially they will helpful in the hand functioning. So it is going to be a combined teamwork. Thank you.
Thank you, Doctor. Dr. Shankar, could you talk to us a little bit about mechanical thrombectomy?
Is mechanical thrombectomy is it's like a most recent method to take out the clot through an aspirating tube. So whenever the clot is not responding to the clot busters, the blood flow is not restored. So we need to open up the blood vessels mechanically. So this is done in a sophisticated cath lab that is exclusive for neuro cath lab. So all the team is important in performing it. We make a small puncture in the blood vessel. We pass a catheter all the way up to the clot, and we try to aspirate with the help of an aspiration pump system. And sometimes the rigid clots, it will not get aspirated, and we may need to use a stent retriever. It's like a stent, which is usually deployed for blocks, but the stent will be attached to a wire. So the stent will engage the clot very well, and when we pull out, it will easily take it out. So this method is something promising, and nowadays more and more refined methods are coming up in opening up even complicated blood vessel blocks. So it previously there was only tablets like aspirin for stroke, and then came the IV thrombolysis, and now we are in the era of mechanical thrombectomy. We can open up any complicated blood vessels with the help of advanced technology. Thank you.
Thank you. I think we'll just move on to the last couple of questions now. Dr. Jayaprakash Khanna, there are some questions about the impact of diet on stroke risks and what happens to your diet after a stroke.
See, basically, the post-operative diet, it's going to be in what we called as a rice tube, because most of our patients are not going to be fully conscious. And immediately after the post-operative period, we are going to step into the rehabilitation that we were talking. And this nutrition, intake, output, hydration is all going to be part of our rehabilitation work. So this uh, diet that we are going to start in the post-operative period, it's not going to be our routine food. It is going to be a formula feeds. So we are going to calculate exactly how much of the calories is, how much of the protein that we are going to supplement the patient, how much of the essential minerals we are going to supplement to the person, apart from the water. So everything, it's not going to be the food or the diet that we are going to give it to the patient, what we take. It's going to be entirely like a formula feeds, just like a baby, but with a adult or a pediatric need. Preoperatively, I would like Dr. Shankar to update you on this diet control and other modification factors.
So yes, when we talk about diet to prevent a stroke, which is one of the important thing, nowadays carbohydrates is considered as the new era of alcohol. So nowadays we are seeing patients, a lot of patients, they consume carbohydrates thinking it's healthy, and finally land up its excess is converted into fat and it gets deposited everywhere. So a high protein diet and a more of fibrous diet like plant proteins, fibers, and these are considered as healthy. People think like carbohydrates in different forms would help. That is also not the true. So the less the carbohydrates, the more the protein and the fiber diets is the best for to prevent a stroke. So even like food is important for patients before stroke or after stroke, but this balanced diet is essential. And as rightly pointed out, those who got a severe swallowing issue after the stroke, we have a special team to address the nutritional needs. So our speech and swallow rehab specialist will assess at what consistency is best for them to swallow, and they come up with different type of feeds which are easy and safe for them to swallow. And also, like, we gradually give stimulations to the pharyngeal muscles to make them swallow different types of foods, starting from liquid, semi-solids, and then gradually to solid foods. Some may take time; those they may need a special form of a peg tube, just directly, because the rice tube is something small, and we cannot give a thick solid foods through that, semi-solids through that. So we make a small puncture through the skin directly. It enters the stomach bag, so we can give some semi-solid foods to bring up the nutritional needs of the patients also. So before stroke, after stroke, just always a balanced diet is important. And after stroke, they will need the specialist advice and the support from them to lead a normal life. Thank you.
Thank you very much. I think we have just finished about on time. Thank you, doctors.
Thank you.
Thank you very much.
Thank you, audience members, for your participation.
Thank you so much.